Welcome all for the today's session. So we continue with our oncology series, and today is the last part of the CA endometrium. That is the management of CA endometrium. Again, this is based on the FIGO Cancer Report 2021, Cancer of Corpus Uteri 2021 update. Okay, so staging we have learned already from FIGO Report 2023, and the rest of the etiopathogenesis, the types, the molecular classification, everything is we are taking from the FIGO Cancer Report 2021. Okay, now the management, this line you have to keep in mind, and it should be on the tip of your tongue. Management of CA endometrium depends on the stage, the histological type, grade, LVSI, molecular subtype, fertility wishes, and the fitness for the surgeries. So these are the factors which will decide the management of the case. Okay, so now you may be asked about the overall management of the CA endometrium. So it will be a broad question, discuss the management of CA endometrium, or you may be asked regarding some specific stage. Maybe they will mention about early stage disease or late stage disease, or there may be question on fertility sparing surgery. Okay, so depending upon the context of the question, you will be answering. So we will discuss this management with respect to the overall management as such for the C endometrium, as well as stage specific also. Okay, so coming to the overall management approach, the management of endometrial carcinoma can be broadly divided into one, early stage disease, second, advanced disease, and third, fertility sparing treatment. So these are the three headings under which we are going to discuss this management. So early stage disease, primary management is a surgical management, and it is hysterectomy plus bilateral salpingo-oophorectomy, and appropriate assessment of the lymph nodes. Adjuvant treatment will be required according to the risk group. So this is the standard for early stage disease. Primary management, surgical, that is hysterectomy plus bilateral salpingo-oophorectomy. Appropriate assessment of the lymph node we have to do. Then adjuvant treatment as per the risk group. Then what are these risk group, that we will discuss subsequently. Okay, second is a advanced disease. Okay, in advanced disease, what you need to do, it is a cytoreductive surgery in selected patients. Okay, so here you have to reduce the tumor burden, so we'll go for cytoreductive surgery plus chemotherapy, radiotherapy, hormonal therapy in selected hormone sensitive tumors, and targeted therapy in appropriate patients. Okay, so when we say that it is a early stage disease, early stage disease means stage 1 or stage 2, and advanced disease is a stage 3, stage 4 disease. Okay, now coming to the fertility sparing treatment. Okay, so fertility sparing treatment is it is only for very selected patients. Okay, so which are these category of patients? The patient should have endometrioid variety of endometrial carcinoma. It should be low grade disease. Disease should be confined to the endometrium, and there should be strong desire for fertility. Okay, so these are the indications for fertility sparing treatment, or prerequisites, I would like to say, that it should be endometrial histopathology, it should be low grade disease, disease should be confined to the endometrium, and strong desire for fertility. Okay, then now let us talk about the surgery for this endometrial carcinoma. The standard surgery is a total hysterectomy plus bilateral salpingo-oophorectomy. That is the standard surgical procedure. Okay, so TH plus BSO is the standard surgical procedure. This is the standard surgical treatment for most operable endometrial cancers. And what is the surgical approach? Surgical approach is a minimal invasive surgery. Okay, so you should use either laparoscopy or robotic surgery as far as possible, depending upon the facility, rather than going for laparotomy. Okay, so this is what the update, cancer update says. So minimal invasive surgery is preferred when feasible. Laparoscopic or robotic surgery will reduce the blood loss, hospital stay, and post-operative morbidity. Okay, so endometrial carcinoma is primarily stage surgical. Okay, so it is a surgically staged malignancy. Now, what about the radical hysterectomy? Do we need a radical hysterectomy for CA endometrium? Last time also we discussed. Usually we do not require radical hysterectomy. It is a total abdominal hysterectomy with bilateral salpingo-oophorectomy. That is the standard surgery. Okay, so radical hysterectomy is not routinely required for endometrial carcinoma. It may be considered in selected cases where you have an extensive cervical involvement, parametrial involvement and disease requiring en bloc dissection. Okay. So however, for most patients, what is sufficient is a total hysterectomy is sufficient. And if there is a cervical stromal invasion, which stage it is seen? It is seen in FIGO stage 2. So cervical stromal invasion is seen in FIGO stage 2, but all stage 2 does not automatically require a radical hysterectomy. Okay. So you have to decide how much is the cervical involvement, is there a parametrial involvement, and then you have to go for a radical hysterectomy, which is routinely not required. Then we talk about ovarian preservation, because now we are going step by step. First, we discuss about the standard surgery. We mention about the total abdominal hysterectomy with bilateral salpingo-oophorectomy. Then we mention about the route. Okay, so what should be the route? It should be minimal invasive route. Okay, then what we mentioned about, is the radical hysterectomy required? No. Then in THBSO, should we always remove the ovary? So standard operative is the removal of the ovaries, but in selected young premenopausal women with low risk of endometrial carcinoma, ovarian preservation may be considered. But it is in selected young premenopausal women with low risk endometrial carcinoma. Okay, so conditions which will favor the ovarian preservation are: the patient should be premenopausal, then young age, low grade endometrial carcinoma, early stage disease, no evidence of ovarian involvement, and no strong hereditary ovarian cancer risk. So if these criteria are fulfilled, then you may consider in selected young premenopausal women conservation of the ovary. However, avoid ovarian preservation when you are dealing with high-grade tumor, serous carcinoma, clear cell carcinoma, carcinosarcoma, advanced disease, suspicion of ovarian involvement, and Lynch syndrome, where it is a familial cancer syndrome, okay, or high hereditary risk. We are not going to go for ovarian preservation. Okay, so routine BSO remains standard, but ovarian preservation may be considered in carefully selected young women with low risk disease. Okay, now next step is a lymph node assessment. So first we discuss about the standard surgery. Okay, then we discuss about this whether to remove the ovaries or not. Now we are going to talk about lymph node assessment. Very important concept. Okay, now what are the options which are available regarding the lymph node assessment? We have three options. One is a sentinel lymph node biopsy. Second is a systematic pelvic lymphadenectomy. Third is a pelvic plus para-aortic lymphadenectomy. Okay, so these are stepwise. If you see, the things are going more and more extensive. Sentinel lymph node biopsy, least invasive. Then more invasive is a systematic, but we are restricting ourselves to the pelvic lymphadenectomy. Then pelvic plus para-aortic lymphadenectomy. So these are the three options which are available. Now let us see what is removed in and what is the extent. So SLN biopsy, that is the sentinel or the first draining lymph node is removed, and that is the least extensive procedure. Okay. Then next is the systematic pelvic lymph node. Here multiple pelvic nodal stations are removed, and this is more extensive. And third is a pelvic plus para-aortic lymphadenectomy. Here pelvic plus para-aortic lymph nodes are removed, and this is most extensive. Okay, so this concept is very important. You can take the photograph of this. The choice will depend upon the histology, the grade, the myometrial invasion, LVSI, molecular subtype, stage, and the risk group. Okay. Sentinel lymph node mapping, we have last sessions we have discussed 2-3 times. I'll just cover because this can be a separate short note. The sentinel lymph node is the first lymph node draining the primary tumor. If the sentinel node is negative, extensive lymphadenectomy may be avoided in appropriately selected patients. Advantage of this is that it gives you the accurate staging. It reduces the surgical morbidity, and there is a reduced risk of lymphedema, lymphocele, and vascular and nerve injury risk is removed. But when you do the sentinel lymph node mapping, at the same time you have to go for ultra staging. Now, what this ultra staging, that also we have discussed in last session. Sentinel lymph nodes should undergo pathological ultra staging because small volume metastasis may otherwise be missed. Okay. Now, very important, come to a very important concept, that is the risk group. Okay, so this endometrial carcinoma disease as such is divided into different risk groups. Okay, so you have total 4 groups. Okay, low risk, intermediate risk, then intermediate high risk, and next is a high risk. Okay, so intermediate you have 2. intermediate and intermediate high, and then there is a high risk. Okay, so what comes in which risk? Because your adjuvant treatment, your lymph node dissection, all will depend upon which type you are dealing with. Okay, whether it is a low risk disease, whether it is an intermediate risk disease, whether it is an intermediate high risk or high risk. Okay, so in low risk we are dealing with low grade, that is grade 1 and grade 2 endometrial carcinoma. Where tumor is confined to the uterus, there is a superficial invasion and no substantial LVSI. That means it is a low risk disease, and routine systematic lymph node dissection usually not required here. So when we are dealing with low risk, having grade 1 or grade 2 endometrial, where the malignancy is confined to the uterus or only superficial invasion without any substantial LVSI, lymph node dissection is not required. Then you have intermediate risk, okay, where there is a deeper myometrial invasion, grading is a grade 2 or grade 3 or other adverse pathological features. You will consider or perform nodal assessment. Okay, so first you assess the sentinel lymph node and then you decide further. Okay, so here consider or perform nodal assessment. Next is an intermediate high risk, where there is a substantial LVSI, high grade disease, or multiple adverse features. Okay, here nodal assessment is important. So you have to do the nodal assessment here. Okay, in intermediate high risk. And next is a high risk, where you are dealing with the serous, clear cell, carcinosarcoma, undifferentiated carcinoma, and advanced disease. Even it may be grade 3 endometrial carcinoma. Okay, endometrial variety of grade 3, because grade 3 is here also, here also, and here also. Okay, so but here it is an advanced disease with multiple pathological features. It will be a high risk disease, so thorough staging is required and nodal assessment is required. Okay, now let's see one by one. Okay, I hope you have understood these four risk. Okay, so low risk. Here, routine systematic lymph node lymphadenectomy is generally not required. In intermediate or high risk disease, nodal assessment becomes increasingly important, while in high risk histology, consider more extensive nodal assessments such as serous carcinoma, clear cell carcinoma, carcinoma sarcoma, grade 3 disease, deep myometrial invasion, and extensive LVSI. We will go for extensive lymphadenectomy. Okay, now why lymphadenectomy not done routinely in every patient? Okay, why we say that low risk disease lymphadenectomy is not required? Because many endometrial cancers are presenting in an early stage. Okay, systematic lymphadenectomy has got a significant morbidity. It does not provide survival benefit for all low risk patients. Okay, so because survival benefit will be lost, you are going to give lot of morbidity. Okay, so automatically survival benefit for the low risk patients will be lost, and sentinel lymph node assessment can provide staging information with less morbidity, because you are getting the same information by sentinel lymph node assessment. Okay, so lymph node assessment should be individualized according to the patient's risk of nodal disease rather than performed routinely in every low risk patients. Okay, so low risk patient, this is not a routine procedure. Okay, you have to do individualization, and these are the reasons why every low risk patient does not require a lymphadenectomy. Okay, now the risk grouping, we have just seen it. So this risk stratification is fundamental because it determines whether adjuvant treatment is required and what type of adjuvant treatment we need to give. Okay, so not only pelvic assessment, lymph node assessment, but the adjuvant treatment is also depending on this risk group. Okay, so what are the important determinants? This is the same: FIGO staging, histological type, grade, myometrial invasion, LVSI, nodal status, and molecular subtype. That will decide the risk group, that is the low risk, intermediate risk, intermediate high, or high risk. Okay, so low risk endometrial cancer. What are the characteristics of this low risk endometrial cancer? The typical characteristics are: it is a stage 1A disease, endometrial histology, grading grade 1 or grade 2 disease, there is no or substantial LVSI is absent, then no high risk molecular pathology. Okay, no high risk molecular subtype. So this is the low risk endometrial cancer. Here, surgery alone is more than sufficient. No routine adjuvant treatment is required. Okay. Then next is the intermediate risk disease. Here, it is also a stage 1 disease, grade 1, grade 2 disease, but deep myometrial invasion and selected LVSI positive tumors. Okay, Here, adjuvant treatment will include vaginal brachytherapy is must here, and external beam radiotherapy in selected patients. So what is must here? Vaginal brachytherapy. Here it was surgery alone. That means PHBSO plus lymph node assessment. Okay, in low risk disease. Okay. Then lymph node also assessment we are talking about. Consider assessment. If it is positive, then we will decide further. Okay. Here the surgical treatment plus vaginal brachytherapy gets added. No adjuvant treatment is required in low risk disease, while in intermediate we are adding the vaginal brachytherapy and we are considering external beam radiotherapy in selected patients. So here EBRT is SOS. Okay, so the decision depends on the complete risk profile. So you have to again see all those parameters and then decide, take a decision. Then coming to the high intermediate risk. Okay, here also you have a grade 3 but deep myometrial invasion, substantial LVSI, patient is elderly patients and high risk histology. Okay, now what you require here, it is mainly the vaginal brachytherapy, EBRT and chemotherapy in selected high risk situation. So here brachytherapy is also there, EBRT is also there, and chemotherapy in selected. So we are going stepwise. First surgery alone. Here no adjuvant in the low risk. In intermediate, adjuvant is required, mainly vaginal, EBRT, SOS. Here vaginal plus EBRT and SOS chemotherapy is required. Now come to the high risk endometrial carcinoma. It includes the serous, clear cell, carcinosarcoma, grade 3 endometrioid carcinoma with adverse features. Okay. Then P53 abnormal tumors, advanced stage disease, nodal involvement. So tumor will require surgery plus chemotherapy plus minus radiotherapy. Okay, so this is what is the overall treatment. So when you are asked about the overall, then you should write overall treatment. Okay, so this is about this overall treatment. And next is the adjuvant treatment. Okay, so we discuss about the surgery, lymph node. Now come the adjuvant treatment. There are two important forms of radiotherapy. One is a vaginal brachytherapy and a second is a external beam radiotherapy. And you will select depending upon the risk category of the disease. Okay, so vaginal brachytherapy. Why vaginal brachytherapy is important? Because most local recurrences will occur in the vaginal vault. Okay, endometrial carcinoma recurrence is known to happen in the vaginal vault. Therefore vaginal brachytherapy can reduce the vaginal recurrence, and advantage is that it is a short treatment, limited toxicity, excellent local control, particularly useful in selected intermediate risk patients. Okay, vaginal brachytherapy is not equivalent to the pelvic EBRT. Okay, so intermediate risk patients, you will definitely give vaginal brachytherapy. Now next is a external beam radiotherapy. So EBRT may be used when there is a significant risk of pelvic recurrence, nodal recurrence, and extrauterine disease. So if you have, there is a significant risk of these things like pelvic recurrence or nodal recurrence or extrauterine pelvic disease, then particularly it is considered for patients with substantial LVSI, cervical stromal involvement, nodal disease, high risk histology, and advanced stage. We will go for EBRT also. So next adjuvant is a chemotherapy. Okay, so the commonly used regime is a carboplatin plus paclitaxel, same what we use in ovarian also. So this is an important combination for advanced disease, high risk disease, serous carcinoma, carcinosarcoma, and recurrent disease. Okay, so most commonly used chemotherapy combination, if you are asked in endometrial carcinoma, it is a carboplatin plus paclitaxel. Okay, now we will go for stage wise this management. I hope you have understood the overall management. Now let's see about the stage wise management. Okay, so FIGO stage 1. Okay, in stage 1 also we have stage 1A, which is a low grade endometrioid. So typically you are dealing with endometrioid variety of carcinoma, grade 1 or grade 2, less than 50% myometrial invasion, and there is no substantial LVSI. So if we are dealing with this early stage or stage 1A disease, you go for total hysterectomy plus bilateral salpingo-oophorectomy plus minus sentinel lymph node assessment, but no adjuvant therapy is required in stage 1A. Okay, now stage 1A, but it is a high grade or a high risk histology, such as grade 3 endometrioid or serous carcinoma or clear cell carcinoma or carcinosarcoma. See, here the histology is different, but it is a stage 1A disease. previously it was a stage 1A disease only, but the histology was grade 1, grade 2 endometrioid. Okay. Now here, what is the management? You will go for surgery plus appropriate nodal assessment, followed by consideration of vaginal brachytherapy, EBRT, and chemotherapy, depending upon the risk profile and molecular subtype. Okay. So these serous, clear cell, and carcinosarcoma will change this. Even if it is a stage 1, you may have to add this. Okay, for this grade 3 endometrial and all those things. Okay, so this is what you have to remember. Then coming to the stage 1B, the typical scenario here is you are dealing with endometrioid carcinoma with more than 50% myometrial invasion. The primary management is going to be surgical, that is total hysterectomy with bilateral salpingo-oophorectomy and appropriate nodal assessment. So this is what is the standard management, but you will definitely require adjuvant therapy here, and it will depend on the grade, LVSI, age of the patient, histology, molecular subtype, and possibly you will require vaginal brachytherapy, EBRT, or chemotherapy in high-risk disease. Okay. Now coming to the stage 2. Stage 2 is a condition where you are going to have cervical stromal invasion without extension beyond the uterus. So disease is still in the uterus, but the cervical stroma is involved, not the glandular involvement. Okay. So here again, surgery is required. Total hysterectomy plus bilateral salpingo-oophorectomy plus appropriate nodal assessment, followed by adjuvant radiotherapy. Chemotherapy is optional depending upon the risk. Okay. So do not automatically write stage 2 radical hysterectomy. This we have already mentioned. Okay. So modern management is individualized, and radical hysterectomy is not routinely required. Now stage 3 and stage 4 are the advanced disease. Okay. So stage 3 will indicate that there is a local and regional extrauterine spread. The treatment is, if the case is operable, then you will go for surgery, which is mainly cytoreductive surgery, followed by chemotherapy plus minus radiotherapy. Okay. So stage 3 also we have discussed, it is stage 3A, 3B, 3C. Okay. So 3A where there is a serosal and adnexal involvement, 3B where there is a vaginal and parametrial involvement, and stage 3C where there is a lymph node metastasis. Okay. So stage 3C is further divided into stage 3C1 where there is a pelvic lymph node mets, and 3C2 where there is a para-aortic lymph node mets. Okay, along pelvic may or may not be there, but para-aortic are definitely involved. Okay, so generally treatment here in stage 3 is a systemic chemotherapy plus radiotherapy. Surgery when it is appropriate. So it is not a primary mode, but if appropriate, then only surgery, otherwise systemic chemotherapy plus radiotherapy. Okay. So because nodal disease indicates the significant risk of pelvic recurrence and distant mets. Therefore, systemic therapy becomes particularly important. Okay. Now coming to the stage 4. So stage 4 is divided into stage 4A and 4B. There is also stage 4C also. So bladder and bowel mucosal involvement is seen in 4A. 4B is the distant mets. So management will depend upon the extent of the disease, symptoms of the patient, resectability, performance status, molecular subtype, hormone receptor status, and the previous treatment. So options for stage 4 are the surgery in selected patients only. Okay. Chemotherapy, you have radiotherapy, hormonal therapy, and targeted therapy here comes. That is the various biological agents are there. Those can be used. The immunotherapy is there. Okay. So stage 4 disease is predominantly a systemic disease and requires individualized multimodality treatment. Okay. Now, what is the role of hormonal therapy in carcinoma endometrium? Okay, so hormonal therapy is particularly important in low-grade endometrioid carcinoma, where the estrogen receptor, progesterone receptor positive disease is there, recurrent disease, patients with who are unsuitable for surgery, and fertility sparing treatment is required. In those cases, we go for hormonal therapy. Okay, so which patients are benefited by hormonal therapy? Low-grade endometrioid carcinoma, where the disease or there are estrogen and progesterone positive disease is there, recurrent disease, patients who are unsuitable for surgery, and fertility sparing treatment is required. These are the indications for the hormonal therapy. Now, drugs, which are the hormones which are used? Progestrogens are used, magistral acetate, medroxyprogesterone acetate, and LNG, that is levonorgestrel releasing IUS. So these are the progesterones which are used. Now coming to the fertility sparing management. Okay, so fertility sparing treatment may be considered in carefully selected patients. Ideal candidate for fertility sparing surgery is the one who has got a strong desire for fertility. The patient is in a young reproductive age group. Endometrial carcinoma, which is grade 1, disease is confined to the endometrium, no myometrial involvement, no extrauterine disease, that is no ovarian involvement also, no contraindications to the hormonal therapy, and patient should be willing for close surveillance. So these are the indications for fertility sparing surgery. Okay, so what is the fertility sparing treatment? Okay, not the surgery as such, fertility sparing treatment. Okay, here in C endometrium, main treatment is a hormonal therapy. So what we use a progesterone therapy. Okay, so options which are available with us are oral progesterone, the LNG IUS, and combination approaches in selected patients. Okay, now how do you assess the response of the patients? What we have to do, we have to repeat the endometrial sampling and hysteroscopic assessment we have to carry out. So important is that fertility sparing treatment is not the standard oncological treatment. It is an alternative for highly selected patients. So patients should fulfill the criteria, then only you pose this patient for fertility sparing treatment. Okay, provided they are fulfilling those criteria what we mentioned. So but it is not a standard oncological treatment. Okay, and but the surveillance is must once you go for fertility sparing. Then what after complete response? Now you are giving the fertility sparing treatment and there is a response, then what you do? Okay, once complete response is achieved, then attempt conception, you need to refer to the ART specialist. Okay, so ART treatment may be considered, and after completion of the fertility, definitive hysterectomy should generally be recommended. So this is what is the complete treatment for these patients, those who are willing for the fertility. Okay, so ultimately you have to go for definitive hysterectomy after the fertility treatment. So ART referral is required. After completion of fertility, definitive hysterectomy we have to consider, because conservative treatment does not eliminate the underlying risk of recurrence. Okay. Now something about the recurrent endometrial carcinoma. Okay, in recurrent endometrial carcinoma, management will depend upon the site of recurrence, previous treatment, disease-free interval, molecular subtype, hormone receptor status, and the performance status of the patient. If there is a localized recurrence, then we may consider treatment with surgery, radiotherapy, and both will depend on the previous treatment. Okay. And if it is a disseminated recurrence, then usually systemic therapy is required. Okay. Now, newer concept is a molecular based treatment. Okay, so modern management increasingly incorporates the molecular subtype. Okay, so various various these biological agents are available, and they are used depending upon these molecular classification. Okay, so lot of details are not required, but just basic understanding is more than sufficient here. So modern management increasingly incorporates molecular subtype. You may not remember the names of the drug. Okay, so Polmute classification, we know that it has got excellent prognosis. It may allow reduction in the treatment intensity in selected circumstances because it has got a excellent prognosis. So intensity of the treatment may be reduced. If you have got a MMRD group, then it is important for prognosis. We have to evaluate these patients for Lynch syndrome. Okay, and selection of immunotherapy in advanced or recurrent disease. So depending upon the germline affection, you have to select the immunotherapy. Then next is a P53 abnormal group. Here high risk biology is there, so often requires more intensive treatment. And last category is NSMP. So this is intermediate group. Treatment depends upon the conventional pathological risk factors and the hormone receptor status. Okay, few words about immunotherapy. Okay, so especially in MMR deficient or microsatellite instability, high endometrial cancer, if the MSI is high, endometrial cancers may respond particularly well to the immune checkpoint inhibitors. Okay, so in immunotherapy, what we use immune checkpoint inhibitors, and examples are pembrolizumab, then dostarlimab. Okay, so these are the drugs which are used. These are the immune checkpoint inhibitors. This is particularly relevant in advanced disease, recurrent disease, and MMR deficient and MSI high tumors. Okay, so even if you mention immune checkpoint inhibitors, that is more than sufficient, because this is FIGO 2021 update, and these treatments, there is a lot of what you can say, updates are going on. So there might be little change also currently, but whatever is the latest this FIGO 2021 report that I am mentioning. Okay. So coming to the management algorithm of endometrial carcinoma. So we will confirm the histology, then we will assess for the histology, grade, myometrial invasion, LVSI, cervical involvement, nodal status, molecular subtype, and early disease, we are going to go for surgery. Okay, so surgery is a standard surgery, total hysterectomy plus bilateral salpingo-oophorectomy, appropriate nodal assessment. Then we'll carry out the risk stratification. So what is the risk? Whether it is a low risk, intermediate high, or high risk. Okay, for low risk, surgery alone is sufficient. Intermediate risk, surgery plus vaginal brachytherapy is required. EBRT is optional. High risk, surgery plus chemotherapy plus radiotherapy is required. And advanced or recurrent disease, mainly the systemic therapy plus surgery plus radiotherapy. Okay, so this is just the snapshot of what we have discussed. Stage 1A, which is a low risk, where disease is confined to the uterus and invasion is very superficial, you go for surgical treatment, EH plus BSO, and go for lymph node sampling. Usually no adjuvant treatment is required if you are dealing with 1A high risk. Okay, so this actually the older classification we have taken, because the management is okay with the older classification. That is fine. Okay, so high grade and high risk histology, here you will go ahead with the surgery plus nodal assessment and radio and chemotherapy. Then 1B, okay, where more than 50% myometrial invasion is there, surgery plus nodal assessment plus minus adjuvant treatment. Now stage 2 is also early disease, but the cervical stromal involvement is there, so go for surgery plus nodal assessment plus chemoradiology. Okay, stage 3 and stage 4 are advanced diseases. In stage 3, you have a loco-regional extrauterine spread. So surgery when feasible, but chemo, radio you need to add. Stage 3 is a nodal disease. So systemic chemotherapy plus radiotherapy commonly required. Stage 4 and 4B. 4A is a bladder bowel mucosa, individualized multimodality treatment. 4B is a distant meds, primary systemic chemotherapy plus minus local treatment. Okay, so from examination point of view or viva point of view, standard surgery, total hysterectomy plus bilateral salpingo-oophorectomy. Routine radical hysterectomy required? No, it is not required. Nodal staging option. First, you go for sentinel lymph nodes mapping. Okay, so what is the advantage of sentinel lymph node? It reduces the morbidity of systematic lymphadenectomy. Common chemotherapy agent is a carboplatin plus paclitaxel. Then common vaginal adjuvant treatment is a vaginal brachytherapy. Pelvic nodal disease is stage 3C1. Paraortic is stage 3C2. Especially in MRCOG, they give you the findings and they ask you specific stage, and this is a EMQ. Okay, so fertility sparing ideal histology is a grade 1 endometrial carcinoma. Okay, that is where you can think of in a very selected patient. Fertility sparing main drug is a progesterone, and definitive treatment after childbearing is a hysterectomy. Okay. So in examination, they may ask you about the broad questions such as discuss the management of endometrial carcinoma. Then you will write under introduction, histological diagnosis, preoperative assessment, FIGO staging, surgical treatment, lymph node assessment, risk stratification, adjuvant radiotherapy, chemotherapy, hormonal therapy, stage-wise management, fertility sparing treatment, and recurrent or advanced disease and follow-up. So these are the headings under which you are going to write. Or there may be long questions such as discuss stage-wise management of carcinoma of endometrium. Here we will write about the stage-wise management, but this particular sentence is very, very important. You should start with treatment is based on the stage, histology, grade, LVSI molecular subtype, and patient's fitness and fertility wishes. Okay. Then there can be various short notes such as fertility sparing management of endometrial carcinoma. Okay. In a viva question, they can ask you about commonly used chemotherapy regimen, which is carboplatin plus paclitaxel. Which radiotherapy is particularly useful in preventing vaginal recurrence? Vaginal brachytherapy. Ideal candidate for fertility sparing treatment is young woman with grade 1 endometrial carcinoma confined to the endometrium without myometrial or extrauterine disease. Main treatment for fertility preservation is a progesterone therapy plus minus LNG-IUS. What should be done after completion of fertility? Definitive hysterectomy should be advised. Okay. So this is the same thing what we have seen. Okay. Molecular classification also we have seen. Pol has got excellent prognosis. P53 has got a poor prognosis. That finishes the today's topic of endometrial carcinoma. Thank you.